Hello and welcome to the April 24th episode of APHA's 15 on COVID-19 series. I'm your host, Dan Zlott, Vice President of Education here at APHA. Today we're going to be taking a look at some updates on new viral properties as well as some new information that's come out about Remdesivir. Certainly a lot of rumors flying around the last day or two, and so we will do our best to dig through those and see what we can come up with. So with that, let's go ahead and jump right in. As usual, I have nothing to disclose. Here are your learning objectives for today. All right, well, let's go ahead and get started with some of the viral properties. So the first one I'd like to revisit is aerosolization. So it turns out that there's increasing evidence that the SARS-CoV-2 virus, or the COVID-19 virus, is more easily aerosolized than we originally thought. And that's a little bit interesting because actually there was great data early on that came out of the Rocky Mountain labs from NIAID, the National Institute of Allergy and Infectious Disease, and they pretty clearly showed that the SARS-CoV-2 virus was stable in very small aerosolized droplets, we call those micro droplets, for at least 3 hours. Now, some of the criticisms there was that these droplets were artificially generated, and a lot of the experts were saying up front that people aren't capable of creating these types of micro droplets, and so that wasn't necessarily a realistic recreation of what you'd experience from a human. So humans create larger respiratory droplets, and those droplets tend to drop to the ground relatively quickly, and so the risk of aerosolization was somewhat minimal. So in contrast to what some of the experts were saying early on, it turns out that that may not be accurate. And in fact, humans can produce very fine respiratory micro droplets, and that they can linger in the air for several minutes, if not longer. And so this study I'd like to highlight for you is a study from JAMA, and this is actually from a group at MIT, and they used a special type of light capture, a special type of camera, and that allowed them to see respiratory droplets as well as the gas cloud from a human sneeze, which is kind of disgusting, but also fascinating. And so it produced what they called a multi-phase turbulent gas cloud. And so the image here is actually from the article, and you can look at the scale there. That's 7 to 8 meters. So if you think about that, that's like 25 feet, maybe a little bit more than 25 feet. And so there's some special properties in a gas cloud produced by a human sneeze that it's the moisture, the warmth, and what that allows is that these micro droplets that would normally evaporate relatively quickly are carried in this cloud of warm air that's coming from our lungs, that's picking up stuff from our airways, from our mouth, our nose potentially, and it's all being expelled. And that warm gas cloud sort of envelops these micro droplets in a warm environment that prevents evaporation. So the heavier stuff will fall to the ground, but these little micro droplets can float on that gas cloud out to 25 feet or more. And so obviously that's much farther than we initially heard. We were all told 6 feet is enough, and more or less it is. It'll protect you from those big droplets, but from some of these smaller droplets, maybe that's not quite enough distance. And so, as I said, that's about 25 feet of distance. I would really encourage you to check out the link that's posted here. There's a phenomenal video that accompanies this image. We couldn't post it within the slides, obviously, but it is tremendous. It really shows how this gas cloud moves, and you can see over a course of about a little more than 40 seconds how this gas cloud travels these 25 feet, and it's slow. It's just hanging out in the air, and there's no sign of the gas cloud dropping to the ground. It's still suspended there at the end of the clip. So it really gives you an idea of what a gas cloud from a human sneeze really looks like. It's very interesting stuff. So do check that out. So as a result, other groups have started looking at this phenomenon, and they're starting to wonder, well, how else are there other ways that humans can produce these types of micro droplets? And it turns out that a sneeze is not required to produce these fine lingering particulates. So two different groups have utilized laser sheets to track human droplet emissions during speech. So basically take a laser beam and turn it into a laser sheet. If you're familiar with a laser level, it's the same idea, just a little bit brighter. And the image here is actually an image from the first article, which was in New England Journal, and that comes from a group at the National Institutes of Health, and they were tracking emissions during human speech. And so again, this is another article that has a video with it, and you can see there's actually a very strong correlation between the loudness that the person is speaking with and the number of particulates that are emitted. That probably isn't a surprise to anybody who's been around a loud talker. Sometimes things fly out of our mouths when we're speaking loudly, but not just big things. It turns out little teeny tiny droplets, and they can hang around for a while in the air. And so this idea actually, the first time I saw it was from a news report from NHK World, which is a Japanese news channel, and they paired up with the Japanese Association for Infectious Disease, and they ran a very similar study. And in addition, they ran some simulations about these microdroplets. But one of the interesting things that they showed in the NHK World newsreel was they put two people talking to each other in a compartment, and they had it sealed off, so there really wasn't a lot of airflow, and they had this laser sheet there, and you can see the particles just hanging around these two people as they're having this conversation. And so it's very informative. Again, do check out the videos, because the still pictures here just really don't quite do it justice. But what we're clearly learning is that these microparticulates, these micro droplets, hang around in the air for a long time and are potentially a means of transmitting coronavirus. So this is all new, and potentially, reinforces the idea for why we should wear masks. And in fact, in the first video from the group at NIH, they actually have the gentleman who's speaking wear a mask, and you can see there's almost no particulate emitted. So the mask is not necessarily to protect you from getting sick, it's to protect you from spreading things to other people. And so again, it's kind of a great way to demonstrate that visually. So with that, well, let's go ahead and move on now to surface stability. So a number of studies relatively early on demonstrated that the COVID-19 virus was stable on surface for days to weeks. The same group we talked about from the Rocky Mountain labs of NIAID had demonstrated that the COVID-19 virus was stable on various surfaces for several days, 24 hours for cardboard, about 3 days for steel and plastic. The new information here really comes from the Diamond Princess cruise lines, and this isn't terribly new. This is a couple weeks old at this point, but after they'd offloaded all the passengers from the cruise ship that had been quarantined off the coast of Japan for quite a while, they went back 17 days after they'd offloaded everybody, and they still were able to detect viral genetic material on some of the surfaces in the passenger cabins. So clearly we know that there's a good couple of weeks at least where you can find viral genetic material. Now, it's unclear if there are actually viral particles there. I don't think I ever saw a study where they went and tried to plate what they found in like a cell culture to see if what they found was able to infect the cells. But for the most part, it's safe to assume that if you find viral genetic material, you'll probably also find virus. So that's all well and good. These are all sort of, lab-based tests. Are there any real-world examples of coronavirus being present in the environment? So let's take a look at that. So there was a really interesting study that came out of China, Wuhan, China, where this whole event kicked off. And they did surface swabs and air samples in a hospital in a couple different settings. And so those settings were analyzed for COVID-19 viral genetic material using PCR tests. And so they sampled an ICU, they sampled a general ward, sort of a general medicine ward, and then they sampled the hospital pharmacy, which is kind of interesting. So in the ICU, here's what they found. 75% of computer mice, 60% of trash cans, and 43% of bed rails tested positive for COVID-19 genetic material. 70% of floor samples tested positive. Again, not surprising if you think about, all the stuff eventually falls to the floor. But it turns out that 35% of air samples also tested positive. And the photo here is actually the actual device that they used to test. So it sucks air in at the bottom. You can see that inlet at the bottom, and then kind of facing facing us at the top is an outlet. And so it runs all that air through there, and then it basically blows the air up against the collection container, and it captures it if there's anything in there. So 35% of the air samples in the ICU tested positive. So that's kind of scary. I mean, that tells you right there that this is clearly aerosolized and being transmitted in the air. So in the general ward, they found that 20% of computer mice were positive, 0% of trash cans, and 0% of bed rails tested positive. So, probably a little less frantic and maybe more intensive cleaning, but probably the biggest thing is just less frantic than you would typically see in the ICU. In the general ward, 15.4% of floor samples tested positive for COVID-19, which again is kind of interesting, especially when you combine that long surface stability we're talking about. Think of it days, maybe even weeks. So if it gets on the floor and it gets on your shoes, think about that for a second. So in the general ward, additionally, 12.5% of air samples tested positive. So again, further evidence that aerosolization of the virus does occur. Now, after this, they went into the pharmacy, and they didn't do a lot of testing of, there obviously aren't bed rails in the pharmacy, but there are trash cans and computer mice. They didn't test that, but they did test the floor. And what's interesting about that is 100% of the floor samples in the pharmacy tested positive. And that's interesting because no patients were allowed to enter the pharmacy. So the only way the COVID-19 virus got into the pharmacy is on people's shoes. So just something to think about in terms of unexpected or different ways that the COVID-19 virus can spread because of its enhanced stability compared to what we originally thought on surfaces and potentially in the air. So that's what we know so far about some of the viral properties of the COVID-19 virus. So let's turn our attention now to Remdesivir. So there has been a lot of talk about Remdesivir in the last day or two. There are lots and lots of rumors circulating right now. And this was due to a couple of leak studies. So there was a leak study from the University of Chicago that supposedly showed significant clinical benefit to Remdesivir. There was another leak study that was, appeared briefly on the World Health Organization site, and that was said to show no benefit. And so the stock prices of, Gilead, who is the maker of Remdesivir, went up, and then they went down based on these rumors. And so, here on the 15 on COVID-19 series, we really like to try to keep it as factual as possible. So, just a reminder, rumors are just that, they're rumors. And for us, until we actually see data, we can't make any conclusions. So, reports of studies that were leaked, I did some digging. I was unable to actually find those studies to actually evaluate what the studies said, what the analysis was, whether they were well designed or poorly designed, inclusion, exclusion criteria, all the things we would use to try to evaluate a piece of literature. For now, I was unable to find those. So for now, we will not be making any conclusions about that, and we will just leave those news reports in the category of rumors. And when we get more information, we'll revisit. All right, now that we've talked about what we don't know, let's talk about what we do know. So the best data available right now comes from the compassionate use experience with Remdesivir. So this is an open label, uncontrolled case series, and this was conducted in 61 patients. However, there's only data available from 53 of the patients, so this is really a pretty small number. And so geographically, 22 of the patients were from the United States, 22 patients were from Europe or Canada, and 9 patients were from Japan. The intervention here was the typical Remdesivir dosing that you should see in most of the trials out there. It's 200 milligrams IV on day 1, followed by 100 milligrams IV every day for 9 more days, a total of 10 days of therapy. The patients in this study were a little bit of a different patient population than we've seen before. They're a little more ill than a lot of the other studies out there. So 57% of the patients were receiving mechanical ventilation at baseline. Additionally, 8% of the patients were receiving extracorporeal membrane oxygenation or ECMO therapy at baseline. Just for curiosity's sake, the photo here is actually of a patient receiving ECMO therapy. That's a real ECMO machine. And if you notice, there's a little bit of a difference in color between the two blood lines. One of them is a little bit darker, one of them is a little bit lighter, and that just highlights that the machine is taking blood from the patient, that's the darker side, oxygenating it, and then sending it back to the patient, and that's the lighter red color. So just for curiosity's sake. The median age here is 64 years old, so right in line with about what we've seen for the COVID-19 population. 75% male, however, that's significant departure. Most of the literature you read is, 1-to-1 or maybe a very slight bias towards males, but not quite that heavy. So that's interesting. The median duration of symptoms prior to the initiation of remdesivir was 12 days. 68% of patients had comorbidities, and those comorbidities included hypertension, diabetes, hyperlipidemia, asthma. The endpoints of the study, there really were no formal endpoints. However, what they were looking at were changes in oxygenation support requirements, hospital discharge, adverse events, clinical improvement, and they define clinical improvement as either discharge from the hospital or a decrease of at least 2 points from a baseline predefined scale. And here's how they define the scale. 1 point if you're not hospitalized. You get 2 points if you're hospitalized and you don't have any oxygenation supplementation requirements. You get 3 points if you're hospitalized and you require oxygenation via nasal cannula, normal nasal cannula. You get 4 points if you're hospitalized and you require either oxygenation via high flow O2 or high flow nasal cannula or non-invasive mechanical ventilation. Again, that would probably be a CPAP or a BiPAP modality. You get 5 points if you're hospitalized and you require invasive mechanical ventilation, ECMO, or both. And if you die, you get 6 points. So they're looking at your baseline and they're seeing if you decrease by 2 points according to the scale, and they call that clinical improvement. So here were the outcomes. The actual treatment regimens, 75% of patients actually received the full 10-day course. 20%, give or take, received between 5 and 9 days of therapy, and 6% received less than 5 days of therapy. That just helps us know, how much drug did the patients actually get, how much exposure did they actually have. So, most patients got most of the therapy they were supposed to, according to the compassionate use protocol. In terms of clinical outcomes, almost 70% showed improvement in oxygenation support requirements, while 15% of patients showed worse or increasing oxygenation support requirements. At baseline, remember, 57% of the patients were intubated at baseline. So of that initial 57%, another 57% were able to be extubated. So 17 out of the 30 patients were able to be extubated during the course of the study period. 75% of the patients who are on ECMO, and that's only 4 patients, so 3 out of 4 patients were able to be transitioned off of ECMO support over the course of the study. 47% of patients were discharged over the course of the study period. And improvement, and again, that's either discharge or improvement in that score they sort of made up of greater than or equal to 2 points, was seen in 84% of patients, and the 95% confidence interval there is 70 to 99% of patients demonstrated some type of improvement. So is that good or bad? We don't know because there's not a control arm, so we don't have a comparator to know. So that could be good, could be bad, could be just the same as we'd see with the control arm. 13% of patients did pass away over the course of the study as well. So not everything was a positive outcome. All right, next let's move on to safety outcomes. So 60% of patients had adverse events. The most common adverse event were LFT abnormalities, AST, ALT increases, and that occurred in about a quarter of the patients in the study. 23% of patients had serious adverse events, and that included multi-organ dysfunction syndrome, septic shock, acute kidney injury, and hypotension. So it's difficult to tease out whether that's related to the COVID-19 disease itself. Those are all things you might expect in severe COVID-19 disease, or whether that's actually caused by the drug. So they reported them because they occurred in the patient population, but it's not necessarily a causative relationship. So do keep that in mind. 8% of patients had to discontinue remdesivir treatment over the course of the study, and that was due to worsening renal failure in one patient, multi-organ failure in one patient, and increased LFTs in 2 patients. All right, well, let's talk about the limitations and the bottom line. So the limitations of this study, again, it's an open label, uncontrolled case series without a control arm. We just don't know what to make of this information. This was a sicker patient population than has been described in other studies. That's not necessarily a bad thing. We did get some new information about remdesivir in relatively ill patients, but we can't take this information and use it and expect similar outcomes in a not as ill patient population. So we just have to take it for what it is. 75% of the patient population was male. So if there is a difference in outcomes based on whether you're a male or a female with COVID-19 in general, that may impact the outcomes that you would expect to see here. So, if males do worse, then you would expect this patient population to do worse. On the other hand, if males do better, this data might look better than we would see in the full population that included more women. So, again, we just have to take it for what it is and realize that there may be some limitations there. Interestingly, the authors, if you look at the supplementary materials, they had a form that collected information about other antiviral therapies that patients had received in the last 48 hours prior to enrollment. So we know that they had that information. They didn't report on it at all in the supplementary materials that I found or anywhere else. So whether that was because it was not significant or whether because that was only applicable to a certain portion of the population, we don't know. So we'll have to see if there's more information that comes out down the road about that. So what's the bottom line about remdesivir? You're not going to be surprised. Without a control group, as I said, it's impossible to assess the contribution of remdesivir to the outcomes. We did see significant incidence of LFT abnormalities, and that's something we saw in the Ebola patient population as well. Do keep in mind that remdesivir was originally developed as a treatment for Ebola and is now being repurposed for COVID-19. And in Ebola patients, they also saw a significant increase in LFTs in a fair number of patients. So a safety signal there and something that we'll probably see with this drug going forward. Bottom line is, of course, that more data is still needed. So again, not a surprise to anybody until we start to get randomized control trials. That's probably going to be consistently one of our bottom line points. So that will wrap up today's 15 on COVID-19 episode. Thank you very much for joining us. Our next topic for 15 on COVID-19, we're going to take a look at some of the other therapies that are out there. People have been asking a lot about zinc, vitamin C, over-the-counter things, nutraceuticals. So we'll take a look and see what information there is about those. Until then, please keep the questions coming. We continue to receive a lot of great questions. Send those questions to us at covided@aphanet.org, and we will do our best to answer them. Thank you again for joining us. Hope everybody has a great weekend. We hope to see you on Monday.